All right. Well, I will get started just with a few quick announcements. So, welcome everybody to our Friday CFAR clinical conference. A few just notes for upcoming things. So, next week we will have a holiday break. So, happy Thanksgiving to everyone. And then the following week we will have some cases. So, please join us for that. I have a couple. We have an update on one of Julie's cases that we talked about before. Got some basic science stuff back to talk about, give her some help in the management there. But please, and I think I have one from Irene also. So we'll talk about those on the first week of December. And then also just on the horizon for our in-person edition of the CFAR conference for the spring, we have invited Tom Quinn to give an HIV global update, and we will hopefully be able to wrangle pizza for that as well. So please do plan on that in the fall. It's tentatively scheduled for March 20th. So the one other thing I did just want to mention is that, as many of you knew, there was some question of whether the DHHS guidelines panels would remain a funded part of the NIH. Those have existed under the auspices of the NIH with the guidance from the Office of AIDS Research, the OAR. But with the changes in administration and policy, there was a thought of disbanding and or moving the panel. I We discussed that on this meeting. There was open public comment, and many people submitted notes about the importance of the guidelines. And we were just told a couple of last week that the guidelines will continue in their current form under OAR with the NIH. And I do personally believe it's just a really important public service. And so that feels good. There will be just two things, one of which is a clarifying statement at the beginning to say that, this is all just recommendation, but not government mandate, which is totally fine and is correct. And then there's also going to be some emphasis on highlighting research gaps. So places where the guidelines are unclear, and that is to sort of align the guideline document with also the NIH. So it's good news for now. And just wanted to thank any of you who submitted letters. They were identified as the primary reason why the guidelines were allowed to continue. So without any further delay, I will introduce our speaker for today, Dr. Todd Fojo, who comes to us from the Division of General Internal Medicine and is been a leader in the HIV cohort with Richard Moore, and now becoming the leader of that cohort. And he's going to talk to us today about potential federal policy changes on HIV transmission. And thank you so much for joining.
Well, thank you so much. It's nice to have the opportunity to talk to everybody. So to start, I have no disclosures. And the objectives here today are to use a simulation model to project the potential impacts of some disruptions that might happen to federal HIV programs. And I also have as an objective to give everybody a sense of how the transmission model arrives at these projections. If I'm being honest, I probably have a stealth objective, which is to convince everybody that math is kind of cool, but don't hold that against me. And I promise not to put any equations up. All right, so this is the outline. We'll start with a brief overview of federal HIV programs. I'll give a few slides on how the simulation model works, again, with the objective of just giving people confidence that when we make projections, that they're sort of grounded in reality. And then we'll talk about some simulations of what might happen if Ryan White funding is cut, some simulations about what would happen if CDC funding for HIV tests is cut, and then I'll wrap up with some concluding thoughts. So an overview of federal domestic HIV funds in fiscal year 2025. The budget in total is about $7 billion. A little over a third here is devoted to Ryan White and a few other direct care services through HRSA and the Indian Health Service. About a little over a third goes to NIH for AIDS research. And then the rest is CDC HIV prevention and some funds for housing for people with HIV. And obviously a lot of these programs have come under threat in past months. So over the summer, the administration released a draft budget that would end all CDC HIV prevention activities. In the fall, the House Republicans released a budget that ended, again, all CDC HIV prevention opportunities, and also proposed to cut Ryan White funding, parts of it by about 20%. And then I think many of us are probably fairly familiar with disruptions that have gone on in terms of NIH funding in general and for HIV research in particular. That was the sort of parts of the budget that are explicitly HIV focused. But if you also then think about the money that Medicaid spends for HIV care and Medicare spends for HIV care, those pots of money actually dwarf the parts of the federal budget that are explicitly denoted or marked for HIV. And obviously, the recent reconciliation budget will have probably fairly large impacts on Medicaid, which covers a large proportion of people with HIV in the United States. So in general, the sort of variations of the study question that we're going to be looking at with the simulation model is how will X policy change affect the US HIV epidemic? Because our model is geared towards predicting future infections and transmission, that's the primary outcome that we'll focus on, right? Is to say, how much is this going to increase new infections of HIV in the coming years? So with that, I'll spend a little bit talking about how the simulation model works. And before we get into that, the way I think about things, right? If I were to ask, I think most people, what's my principal objective here as a modeler? I think probably most people would say your job is to predict the future. And I would just say when I'm thinking about like running the model and feeding the model, really what I see as my principal role is quantifying the uncertainty, right? So not just saying what I think is going to happen, but really thinking about how do I know that? What are these projections based off of? And putting essentially confidence intervals around the projection. So I will try and highlight that and keep that in mind as we go along. Okay, so with that, the model that we use is what's called a compartmental model. And what it does is it represents the population in different compartments or subgroups of people. And then we make the simplifying assumption that you can represent the average behavior of people in each compartment. So the first compartment we have is people who are HIV negative, uninfected, and attached to that compartment is a proportion of people who are enrolled in PrEP, which we conceive of as both receiving, Truvada, Cabenuva, Descovy, that causes a reduction in your likelihood of getting HIV, but also we presume that means you're, engaged in a program and getting regular screening tests. The next two compartments then are people who have undiagnosed acute HIV, right? They can either be not on PrEP or in a PrEP program, they now have HIV, they don't know it yet, but hopefully they're getting regular tests that will lead to that being diagnosed quickly. And the acute HIV is about the first 3 months when viral loads are really high and the risk of transmission is particularly great. With the passage of time, people can then move into a compartment of chronic undiagnosed HIV. And then as people become diagnosed, they move into a compartment of diagnosed HIV. And there's a proportion attached to that compartment that says how many people are virally suppressed. And in the model, as in real life, people who are virally suppressed cannot transmit their HIV. So those are the 5 basic compartments, but then we split them up by demographic and risk factors, right? So each of these we take and we split into 3 categorizations of sex, MSM, heterosexual male and female, and 3 categorizations based on IV drug use, never active and prior. One limitation, we structured these to represent or to reflect CDC reporting. There's no explicit compartments for trans people. They get categorized the way that they're categorized in the CDC, which means that many trans women are probably lumped in as MSM. And obviously that became a much more complicated question over the past year, but that's the way the model is structured, right? And so now we've taken our 5 compartments, multiplied them by 9, so 45, and then we take those and we further stratify it according to race, Black, Hispanic, and non-Black, non-Hispanic, and 5 age compartments. And so all of a sudden we have 645 compartments in the model of age, race, sex, risk factor, and HIV status. So going back thinking just to the simplified structure, right? The way that the model works is that we need to move people along these lines between different compartments, right? And the way that people move between the different compartments affects basically how the model, how many people the model thinks are infected with HIV, can transmit HIV, and so forth. And each of these transitions between compartments is governed by model parameters. And so what I mean by that, let's think about just this one here, people moving from HIV negative to undiagnosed HIV, so becoming infected, right? We're going to have a bunch of parameters that govern sexual transmission, right? We're going to have a rate of transmission per partnership, a sort of breakdown of, if you are a young male, how many of your partners come from other strata of race, of age, of sex. In the partnering strata, the proportion of people who have HIV and are then virally suppressed. All these things can vary over time. We'll do the same sort of thing for transmission for needle sharing, right? And then we need these not just for one compartment, but for every of the 135 different compartments that represent a combination of age, race, sex, and risk factor, right? And so that ends up being a lot of model parameters, right? And broadly speaking, these are kind of the categories that we use, right? There's parameters that govern population sizes, birth and death rates, prevalence of IV drug use, partner assortativity. There's also parameters that govern how frequently people are getting HIV testing in different compartments, how many people are virally suppressed once they have HIV, PrEP use, and parameters governing what proportion of the population who are male are men who have sex with men. So that's a lot of parameters, right? And we generally fit this model to a specific location, a city or state in the US. And we do that with this process that we call calibration. And basically what calibration means is we want to figure out what parameters governing people moving between compartments gives us a simulated epidemic that looks like the real world, right? And the way that we do that involves a lot of fancy math that I get very excited about, but we basically run millions of simulations to each simulation trying a different parameter to try and find some that reflect the real world well. And the things that we're trying to reflect, when I say reflect the real world, are our targets. So we're trying to recapitulate reported HIV diagnoses, estimates of prevalence, mortality among people with HIV, the proportion of people with HIV who are aware of their diagnosis, the proportion are virally suppressed, how many people are receiving PrEP, how often people are getting tested for HIV, as well as some characteristics of drug use and sort of historical trends in HIV. And so I'll show you some projections here for Baltimore. Before I get into those real quick, when we model cities like Baltimore, we take it as not just the Baltimore City, the county that represents Baltimore City, but the metropolitan statistical area. So for Baltimore, that's Baltimore City, and then the 6 surrounding counties. That helps make the closed system assumption more reasonable. We basically, when we model a location, we say, well, all transmission that's reported in Baltimore is happening sort of within these boundaries. And we modeled a bunch of EHE priority counties. There's 48 of those plus DC. Some of them fall into the same metropolitan statistical area, and so there's 32 EHE metropolitan statistical areas in the US. So when we think about calibration, this is what we're thinking about. Each dot here is CDC reported estimates of the new diagnoses in that Baltimore MSA in a year, right? So these are calibration targets. And then this line here might represent one simulation, right? So the model comes up and says, okay, well, this is it. This one looks relatively close to what we're projecting. You could imagine, right? Maybe we have another set of parameters that gives us this simulation here. And the goal of calibration is to find parameters that give us simulations that look like this one and kind of avoid the simulations that look like this one. So we run that. We explore a million different sets of parameters, and we keep generally 1,000 well-fitting simulations. So it's hard to see here because they're all clumped together, but here I've got a bunch of different lines. It's only 100, otherwise it gets really crowded, but each line here is one simulation. And again, I mentioned we're doing that not just for new diagnoses, but for the CDC's estimates of prevalence, viral suppression among people with HIV, knowledge of status, a bunch of different other outcomes. One thing I'll point out here, this knowledge of status is overestimating some, but these dots are actually the Maryland state level proportion. And so the model kind of knows that and thinks that in the Baltimore MSA, you may have a little better awareness of status than Maryland as a whole. So we're fitting to these targets, right? But we're actually fitting to them on a more detailed level. So if you look at these new diagnoses, right, we're splitting them out according to risk factor. So MSM, heterosexual, people who inject drugs, MSM who also inject drugs. We're fitting them by strata of race, by sex, by age, right? And we're even fitting them at a more granular level than that, right? If you think about these risk categories, right, we're fitting them by the intersection of race and risk factor, right? So MSM by race, heterosexuals by race, right? And we're doing that for sort of all these different combinations, age, sex, risk factor, race. We're doing it for a bunch of different outcomes. And so it ends up being, and I will spare you all the plots that show that, but we're sitting a bunch of different calibration targets at a relatively granular level, right? And all that takes a bunch of work, and we kind of gloss over it here. But the point of that is, right, I want you to have confidence that when we sort of move to the future, that we have recapitulated the recent past, right? And so all that gives us projections. Again, here's those new diagnoses. The model can then project incident infections as they happen. That's obviously something you can't know in the real world, but the model can know everything that happens in a simulation. And we take those projections and move them forward into the future, right? And then going forward, we ask the question of, all right, well, if you perturb the system, affect X policy, what does that do to incidents in the future? So that's the model structure. I should have said too, please feel free to jump in with questions at any time. I've got the chat opened up, and if I miss it, somebody can point out to me that there's a question in the chat. All right. So then the first set of questions that we got into is what happens if Ryan White funding is cut? So I know a lot of us are probably very familiar with Ryan White HIV/AIDS program, but just to recap, it was enacted by Congress in 1990. It ends up providing care to about half of people in the United States. The budget in fiscal year 25 was 2.5 billion, and it's divided up into 5 parts, right? Part A sends funds to cities, Part B sends funds to states, and Part B covers the AIDS Drug Assistance Program, ADAP, which directly can pay for antiviral medications. Part C goes to community groups with a focus on early intervention and capacity building. Part D is community groups with a focus on women, children, youth, and then Part F has training, education, and dental services. So those are the 5 major parts of Ryan White. There's also these initiatives that cut across the 5 parts. So there's the Ending the HIV Epidemic Initiative, which was started in 2019 during the first Trump administration. And that basically provides extra funds for Part A and Part B for specific locations that are designated as priority jurisdiction. There's also the Minority AIDS Initiative, established in 2006, that tries to help populations disproportionately affected. And again, that's not its own pot of money, but it feeds money into the different parts of Ryan White. So our study question was, if Ryan White funded services all went away, how many excess HIV infections would you see going forward? When we focus particularly on 5 years, we did this first in our 31 EHE cities, and then over the summer, we basically were scrambling to bring states online because a lot of policy decisions are made at the state level. And so you'll see for different analyses here, we have different numbers of states, and that just reflects the fact that we were bringing them up as fast as we could. And if you think back to our model structure, right, where that is hitting is that this diagnosed HIV compartment, is specifically the way that this is going to impact transmission is by affecting suppression, right? If losing Ryan White services causes more people to become unsuppressed, there's more HIV transmission that can take place. Ryan White is obviously a big program that does a lot of things in a lot of different places. But in terms of focus on this work, we decided to focus on kind of a simplified representation. So when we think about the ways that Ryan White program will interact with suppression, we chunked up Ryan White services into AIDS Drug Assistance Program, right? So that's people who are either getting their medicines paid for by Ryan White or getting their insurance premiums paid for, which then pays for the medicines, or having copay assistance to help them purchase their antiretrovirals. There's also outpatient ambulatory health services. That's Ryan White funding to help people get to their appointments, right, and see their providers in clinic. And then, and you can have both ADAP and outpatient services. You can have one without the other. And then there's a sort of bigger umbrella of Ryan White services, and things that are in the yellow here but are not ADAP or outpatient health services are generally supportive services, right? So, help with housing, with meal assistance, any range of things that's not directly the medical care, right? And that's obviously a simplification, and Ryan White is customized to do a lot of things in different places, but for the sake of making broad projections, this is the way that we conceived it. So in terms of operationalizing our study question, fundamentally the model needs to know two things, right? In each city or state where we want to make a projection, how many of the people with HIV living there are Ryan White clients? And specifically, how many are receiving ADAP, outpatient health services, or some other services? And the second thing that we would need is to say, okay, well, if these people lose their Ryan White services, what proportion are going to lose viral suppression, right? So the first question is the easier one. Ryan White publishes annual reports that basically say in each city or state how many clients are there for ADAP services, and then for the broad umbrella of non-ADAP services. And it's confusing because you can be receiving both ADAP and non-ADAP services, right? Non-ADAP doesn't mean you don't get ADAP, it just means you get services that are not ADAP services. So we basically expanded the model and added in parameters that let us reproduce how many people with HIV are getting different kinds of Ryan White services. And so here were our calibration targets. This is again in Baltimore City. So this is number of clients receiving non-ADAP services. The dots are what are reported in the reports. And the lines here in blue are simulations. Outpatient health service clients are simulating that. There is, you'd like to know in Baltimore the number of people who are ADAP clients, because the ADAP falls under Part B, which is state level stuff. We don't know that exactly for Baltimore, but what we can say is that across Maryland, about 40 to 50% of Ryan White clients are receiving some ADAP services. And so we simulate for Baltimore to have a similar proportion. We also simulate viral suppression among clients receiving outpatient health services and among ADAP clients. So again, we're sort of hitting these calibration targets. So when I, tell you when we make a projection of if Ryan White goes away, that is grounded in estimates of how many clients or how many people with HIV are Ryan White clients in a particular location. Again, we're doing that not just for the totals, but we're available for straight up race, for age, and for risk factor here. So in terms of the second thing we need to operationalize this, we need to be able to say if someone is a Ryan White client, an ADAP client receiving outpatient health services or supportive services loses Ryan White services, what happens to their suppression, right? And this is a thing that's not well known. We scoured the literature, and there's exactly one study of what happens when people lose services, and that was done in Washington State a few years ago. The certification criteria for Ryan White moved to twice yearly and became more onerous. And so a bunch of people in the wake of that lost suppression. And so they looked and they said, okay, well, of 1,300 ADAP clients who were disenrolled in Washington State, how many lost their suppression, right? And viral suppression among that group dropped from 83% to 69%. So, a modest drop. The thing is that most of those people, 93% of them, re-enrolled in ADAP within the year, right? And in fact, more than half of them re-enrolled within 3 months. And so, that's I think a very valuable study. Is not really reflecting the sort of hypothetical scenario we are envisioning here, where Ryan White just goes away and never comes back. So we ended up not using this and instead going to a survey. We sent this survey out to Ryan White clinic directors, administrators, and health officials, and we said, all right, well, thinking about in your clinic, if Ryan White programs end indefinitely, what percentage of your clients who are Ryan White clients and are currently virally suppressed, what percentage of them would stop taking ART consistently among these groups? And we asked specifically about people who are receiving ADAP services, so in red, people who are receiving outpatient services but not ADAP services in blue, and then people who are receiving any Ryan White services that are not ADAP and not outpatient services, so that's that yellow here. We also asked people sort of what state they were in to get a sense of Medicaid expansion versus non-expansion states. And these, we got 180 responses, and these is a histogram of our survey responses in, and I should put the disclaimer here that I'm colorblind, and so I often forget what specific color I put on the slide. I actually use a program to choose it for me so that I can pick colors that don't look horrible to people who are not colorblind. But I'm going to say this is blue or purple here. And that represents respondents from Medicaid expansion states. And then the orange is respondents from Medicaid non-expansion states, right? So what you see is you got a wide range of responses, right? This is for just thinking about your ADAP clients, right? You have some people who say 100% of my ADAP clients would lose their viral suppression. You have some here who are saying 5% only are going to lose viral suppression if ADAP goes away. On average, for people in expansion states, about 60% was the estimate, the average estimate for losing suppression, and a little higher, 73% for people in non-expansion states. You have less of an effect for outpatient health services, and even less of an effect for people receiving other services that are not directly drug assistance or outpatient health services. So what we did is we took this distribution of responses and we smoothed it and generated 1,000 different values with the idea of approximating this distribution here, right? And the reason we do 1,000 is because we run 1,000 simulations in each city or state. And so each of those simulations has a different simulated value, right? And the point of the simulated value is, again, characterizing that uncertainty, right? I truly don't know how many people are going to lose viral suppression if Ryan White goes away, right? You know, I have my personal bias, but that's my personal bias, right? So rather than telling you, yeah, hey, exactly 60% of clients are going to lose, of ADAP clients are going to lose suppression. Instead, what we're going to do is we're going to run 1,000 simulations, right? And you're going to have some simulations in there where close to 100% of ADAP clients lose suppression. You're going to have some simulations in there where almost no ADAP clients lose viral suppression, right? And the point of that is to characterize our uncertainty, right? Since I don't know how many Ryan White clients will lose viral suppression, I'm going to simulate for you a range of different possibilities. And so basically, these are the values used in each simulation, right? You can see here the expected effects are a little bit worse in non-expansion states than expansion states. So that gives us what we need to operationalize it. And we said, all right, we're going to simulate 3 scenarios, really 4. One scenario where things just continue unchanged. One is a cessation scenario. And again, we were doing this 6 months ago. So we said, what if in July 1st, 2025, all Ryan White services end? And we'll assume that over the next 3 months, we're going to see that viral suppression drop. Whatever it is for that one simulation, you know, if it was 90%, if it was 10%, it's going to take 3 months to get to that. So that was our first scenario. We then simulated a brief 18 months interruption that says, well, what if things go away in July 2025, but services restart in January of 2027? And we'll say that, you know, the program fires back up in January, but it takes about a year for viral suppression among clients to get back up to where it was. And we'll just assume that people who are clients go back to being clients and the viral suppression goes back to what it was. That is probably overly optimistic, but that was the assumptions we made. And then we did a similar one for what if in January 2029, things restart, excuse me, and viral suppression takes a year to recover. And so these are the simulations for Baltimore. So blue here is what if services continue, and then red is what if services stop completely and never come back. For these sorts of things, right, this is again 100 different simulations of the 1,000 we did. I'm going to show you these lines where instead of individual simulations, I give you the mean and then the 95% credible interval, because I find these a little easier to look at. But you see a rise in cases for cessation, you know, a rise that then comes back if you have a longer interruption, and then a rise and coming back for a briefer interruption. If you look at just a 5-year period from 2025 to 2030, in Baltimore, you would see 1,700 more infections over that 5-year period, or 110% increase, basically a doubling of infections, right? And more modest, but still substantial increases in the number of infections if it's only an interruption and services come back. If you scale that up, you take the 31 cities that we simulated and you add the effects for each of those 31 cities all together, this is what you get. over a 5-year period, 75,000 more infections if Ryan White just stops and never comes back, which is almost a 50% increase. And we broke that out by specific cities. I'm showing you all the 31 cities here. I know that's a little too small to see, so I will zoom in on just the top ones, right? The most affected city was Baltimore, so our home sweet home. And this top line is how much of a percent increase you get over 5 years, right? There's that Baltimore sitting at 110% in the cessation scenario. There's the brief interruption in orange, and I want to say green here, or the prolonged interruption in orange and the brief, 18 months interruption in green. So you see a range of values for different cities. Highlighted in orange here on the side are non-expansion cities that are not in non-expansion states, right? And in general, you saw a slightly bigger relative increase in Medicaid non-expansion cities than in expansion cities. But there was a broad range, right? You have Baltimore with a doubling of incidents over 5 years, or a doubling in the number of incident infections than you would have had otherwise. And then Riverside, which has like a 10% increase in California. In terms of thinking what is driving that heterogeneity, there's not one answer, right? But one thing you plot here is if you just say, what's the proportion of people with HIV living in the city who are Ryan White clients, right? You have a positive trend, not surprisingly, right? The more Ryan White, the higher the proportion of people in your city who are on Ryan White services, the worse it's going to be if you take away Ryan White services, right? Here's Baltimore again with a fairly high proportion of residents who are clients and a large impact, right? The other thing we looked at that also has a strong trend is your average transmission rate, right? Which is on average for each person who has HIV, how many new infections are there? And again, higher transmission areas, not surprisingly, if you take away services, more people are unsuppressed, and there's a higher transmission rate in that location, you get a higher impact from ending Ryan White services. So that was in 31 cities, right? We then got a lot of feedback that really these decisions are made at the state level. And, I'm not historically great at thinking about the political implications of my research, but it was suggested that large urban cities might not be the best motivator in terms of who we care about having HIV. So we went ahead and did 11 states, and 11 was frankly just because that was what we could get up and running in 2 weeks with the amount of computational power we had. And so we picked these 11 to have a range of urban, more urban coastal epidemics, more rural, southern, and a mix of expansion and non-expansion states. And so if you then add up the changes in these 11 states, over 5 years, you get 100,000 more infections if you end Ryan White programs, or a 68% rise. Again, smaller effects if Ryan White comes back after 42 or 18 months. And here is the state-by-state thing. It's like that one I showed you, but rotated 90 degrees, right? And you again get a range of responses of effects, with Missouri being the most impacted, Texas the least in relative terms. So, we submitted these pieces. One critique we got from the reviewers right away was, what if your survey responses are overestimating the impact of cutting Ryan White services? By definition, you surveyed people who were invested in Ryan White, and, maybe they're being too pessimistic here, right? You could say, well, do you really think 100% of clients are going to lose suppression? You can kind of by saying, do you think it's zero? You can think in your mind, if you think your guess would be more or less than 60% sitting here in Baltimore. But in any case, we responded to this by rerunning the analyses, but by weighting those survey responses back towards that literature, that data I showed you about what happens if you disenroll people from ADAP. So these were the histograms we used in the regular original analysis. And then this is the histogram of sort of impacts on viral suppression if services go away in our conservative analysis, right? So instead of seeing a 50 to 70% decrease, you see a 27 or 28% decrease. And so here on the top, this is our city level original survey-based analysis. state survey-based analyses, and then here are the corresponding conservative analyses, right? What you see over 5 years, instead of in the city 75,000 new infections, you see 34,000 new infections, so a little less than half the magnitude of effect. Similarly for the states, instead of 100,000 new infections, you see about 30,000 new infections, so a little less than half. So we submitted these, we sent these out, and then in the fall, the House Republicans released a budget that stripped out just parts of Ryan White. Specifically, they said we'll leave Part A and B, but we're gonna strip out Part C, D, and F, and we're also gonna strip out EHE funds, some of which go into A and B, and Minority AIDS Initiative funds going into A and B. And so a reporter asked me about this, and I said, fine, we'll run those simulations too. What happens if you just cut Part C, D, F, and actually we ignored F because F doesn't provide city or state level funds for the most part. So what happens if you cut Part C, D, and the EHE and Minority AIDS initiatives? So in terms of what do we need to operationalize this, it's similar, right? How many people with HIV are getting services supported by those funds specifically that are being cut, and then what proportion of clients are going to lose suppression, right? And so what we said is, in terms of how many people are being supported, well, no ADAP funds are being cut because those parts of Part B were not being touched. So we'll assume that no clients who are receiving just ADAP services are being affected. And then out of the people who are receiving any other services that are not ADAP services, we don't know exactly the counts of people, but what we can say is for a given state, out of all the non-ADAP funds, what proportion of those funds are being cut, and we assume that that proportion of the funds being cut would be an approximation of the proportion of people who are losing services. So to give you a sense, right, this graph here has a bunch of different states, and on the x-axis is the proportion where the denominator is the whole Ryan White budget for the state, except for ADAP. And then the numerator is the funds that are getting cut, right? So you see here, you've got a lot of states where it's about 25, 30% of the budget, of the non-ADAP budget would be getting cut, a few where it's a small amount, and then a few, a number where it's approaching 50% of the budget for the state that is getting cut. They're shaded here by whether or not they are the 7 EHE priority jurisdictions with a large rural burden of HIV are in the orange here. And it's no surprise, right, that those states have a larger proportion of their budget on the chopping block because they're getting extra EHE funds that would be going away. In terms of then the second thing that we need to operationalize is what proportion of clients are going to lose suppression. Well, we said, okay, we have on the model, the model, knows an estimate of how many people are receiving non-ADAP services, and we'll assume that, the proportion of those that corresponds to the proportion of budget being cut experience that same reduction in viral suppression that we saw, that we got from our survey responses, specifically for the effects of losing outpatient or supportive services. And if you run those, you see a 17% increase in infections over the next 5 years, or about 24,000 new infections. Again, you have a fair bit of state level variation. I know this is a lot. The one thing I'll highlight, these arrows here point to the 7 EHE priority jurisdiction states, right? And it's unsurprising, those are the states that have higher impacts from those funds being taken away. All right. So I'll spend the last few minutes here talking about what happens if fund for CDC funds for HIV testing go away. So shifting gears, right? Both the White House and the Congressional Republican budget have proposed to cut HIV prevention activities at the CDC, right? So CDC does a bunch of different prevention activities: testing, PrEP referrals, partner tracing, linkage to care for new diagnoses, syringe service programs, condom distribution, outbreak detection. Their fiscal budget in 2025 was $1 billion. We focus in this work on testing for the primary reason that that's reported really clearly. You could very easily get a handle on it, and we wanted to do things relatively quickly. So if you ask, right, what you would like to know is, hey, out of all HIV tests in the US, how many are funded by the CDC, right? That's something that's impossible to know exactly because nobody records the total number of HIV tests. There was this study by the CDC in 2019. There were in that year 2.4 million tests funded by the CDC, 2.7 funded by other federal programs, and 9.2 million that came from Quest and LabCorp. I will show you a back of the envelope calculation I did here, not formal, but nationally, in terms of all laboratory tests that are done in the US, about 45% are done by Quest and LabCorp. And so, if you fill in, if you assume that this 9.2 million by LabCorp is 45% of the total, you get 20 million tests, and you can kind of back calculate that we're missing 6.2 million tests. So if you have that, if you accept my sort of back of the envelope math here, about 12% of all HIV tests done in the US are probably funded by the CDC. We can say out of all the diagnoses that were made in 2019, 24%, or about a quarter, were made by the CDC, right? And the implication there, right, the positivity rate is higher for CDC testing. In other words, CDC tests are particularly efficient, right? Whereas nationally, you run 1,000 tests, you get 1 or 2 positives. CDC tests, you run 1,000, you get 3 or 4 positives, right? And if you look specifically at their tests that they fund in community centers as opposed to healthcare settings, they're even more efficient, right? 5 to 6 per 1,000. So the study question here is, if all CDC-funded tests stop, HIV tests stop, how many excess infections will you see over 5 years? And we did this study in 18 US states. Thinking back to the model structure, right? What we're looking at with this piece is those diagnoses, right? When you move from the undiagnosed to the diagnosed compartment. So what do we need to operationalize this? We need to know how many CDC tests are done and how many new diagnoses result from those in a location. And then you could assume that those people just don't get tested, but we didn't want to make that assumption, right? We figure somebody who would be diagnosed on a CDC-funded HIV test, some proportion of those people are going to go get tested anyways, right? Through the healthcare provider, through an ED, through somewhere else. So we want to have an estimate of that, right? Basically, if these tests go away, how many people are still going to get tested? So in terms of how many tests are conducted, again, that's reported by state by the CDC. I pick here Texas, one of the states where we fitted, right? They report the number of tests that are funded and the positivity rate among those tests. And there's a little disruption here for COVID times, but you can see here the model, right? We plug those into our model, and our model is sort of reproducing those trends as well. In terms of the second question of how many of those tests would be done even if they weren't available through the CDC, this is, again, an unknowable quantity that we don't know. The best we could come up with, there was this 2022 self-testing program, Together Take Me Home, right? And of the 200,000 people who got tests through that, 48% of them had been tested the prior year, right? So you could say, well, if that reflects sort of all CDC-funded tests, half of those people were getting tested anyways, right? That's a very rough estimate, and I truly don't know how many people would get funded if a CDC-funded test wasn't available to them. But what we did, again, is we said, okay, well, rather than saying 50% for all simulations, we're going to simulate a range of values, and each of those 1,000 simulations is going to have a different value. We randomly varied it from a distribution that had an average of 50%, but there's some simulations with as low as 20. Actually, they're lower, but the 95% confidence interval of what we projected was from 20 to 80%. And so our scenarios here are similar. They were anchored on funding ending on October 1st, which would be the date that a fiscal year 26 budget would have been passed. So you could look back and laugh at us for saying that that's when these changes would take effect. And then we say, okay, what if they restart in January 27 or January 2029? So here's for Texas, right? The bottom line, what happens if there's no change to CDC testing? On the top line, what if testing go away? In Texas, you would see 2,300 more infections, or 9.4, with smaller effects if the testing programs come back after 39 or 15 months. If you aggregate all 18 states together, you see similar sort of magnitudes of effect, 12,000 new infections, or a 10% increase over what otherwise you would have seen. But again, there's a lot of variation by states, right? You have Louisiana leading the pack here with close to 30% more infections than you would have seen otherwise, right? And Maryland, Washington State with relatively modest, small increases in the number of tests and the number of infections you would see from cutting tests. if you ask what drives that effect, right, the single strongest thing, you plot here on the x-axis what proportion of HIV tests in a state were made with CDC-funded tests, right? You've got a pretty strong relationship. That's not surprising, right? The more of your diagnoses that are being made with CDC-funded tests, the worse it is if you take those away, right? And the thing to point out here, right, there's a number of states where approximately half of diagnoses are made with CDC-funded tests, right? And those are the ones that are affected the most. Another thing you can look at, right? We plotted here how rural or urban is the epidemic in a state, and you sort of do that by taking a weighted average of, the census calculates a proportion of population in each county who are in an urban environment, and so if you sort of weight that to the people living with HIV in each county, right, you see this trend here, right, that in general, states with a more rural HIV epidemic were more affected if you take away CDC-funded tests. And the last thing I want to hang out, right, if you look at that parameter that says how many people are going to get their CDC-funded test regardless, even if CDC funding for tests, how many are going to get tested even if a CDC-funded test is not available to them, that is a very influential parameter, right? And the 200 simulations where less than a third of people are getting tested anyways, you see a really large impact, right? And in the 200 simulations here where more than 2/3 of people are getting tested anyways, you see a much smaller impact, right? And so, that number one reflects our uncertainty. Number two, maybe there's a silver lining there, that there's some way we can potentially bend the curve if CDC funding goes away. All right, so I'll move into sort of concluding thoughts, right? So a high level summary here, right? From our simulation model, right? Ending Ryan White, that'll be really bad. 50 to 70% more infections over 5 years. Ending just parts of Ryan White, that's bad. 17% rise in infections. Ending CDC funding for HIV tests, that's bad. About 10%, right? And even if these interruptions last for only a few months or a few years, it's still not good. In terms of limitations of this work, right, one thing is we're looking only at transmission, and our outcome is how many infections are prevented. Obviously, program with particular Ryan White program is not there just to prevent infections, it's there to improve the health of people with HIV, and that is completely not looked at in our analyses. And so we realize, the value of Ryan White is not just in the infections that are prevented. Second limitation is fundamentally we don't know what will happen if these programs halt, right? We don't know how many Ryan White clients will lose suppression. We don't know how many people would not get an HIV test if the CDC wasn't funding it. And, we try and characterize that uncertainty and it's reflected in sort of wide, credible intervals, right? And lastly, each of these studies assumes there's no major concurrent changes. That's obviously not true, right? At some point, Medicaid will end, that will have impacts. But it is hard to do a model where you just do everything all at the same time. And it sort of muddies the water for what the message is. So things that we've got in the pipeline for future work, some cost effectiveness analyses. We're looking at a more comprehensive view of cutting all or more CDC prevention activities. And also on the horizon is we're trying to get a handle on simulating what will Medicaid cuts do to new HIV infections. One complicating factor there is sort of what you think happens with Ryan White funding at that time. So, concluding thoughts, I scratched my head here to try and not make it too depressing. We've made great progress in HIV over the past decades, right? That continued progress is not guaranteed. And if these programs do end, then we're all going to have to sit down and think creatively about what we can do to mitigate the impact. And with that, I'll say thank you. I'm particularly grateful to the team at WHO who worked so hard on this and all the many collaborators that we had. I'm happy to take any questions.
Well, thank you so much, Todd. That was amazing. I'll just start off the questions while people are sort of getting their thoughts together. Presumably, there's some belief that withdrawing this funding, like I would assume that the people who make this policy don't actually intend for HIV diagnoses to increase.
Okay, bye.
And so I wonder, do you have any insights into where they think replacement funding would be coming from, or is there a strategy that they're envisioning that might not lead
Yeah, I
to
don't.
everything
So the
looking
short answer is
bad?
I don't know. And this is again, politics was not what I thought I was, signing up for when I signed up to be a researcher. But yeah, if you're asking me to like explore, I don't know. I mean, I think the best is
Yeah.
that people are sort of hoping that this doesn't happen, right? And the sort of, I think back 6 months ago, I was very worried that Ryan White was just going to be actual hog, right? That
Hmm.
that has not been what's proposed, right? They're proposing a more modest thing, and my sense is that they're trying to think of where can they chip away at things, and maybe there's a belief that the CDC doesn't matter. I don't know. But if you're asking me to sort of articulate the rationale, I don't know that I.
Or even if there's been an offering of sort of competitive models of this not happening, from the viewpoint of like these funding cuts make sense, and because our modeling supports that it won't happen because X or what. No, not really. Okay.
Yeah, I mean, not that I have. I mean, I've seen, right, some internal CDC modeling, and their
Hmm.
projections were dire too. So
Okay.
I don't know
Okay.
that I have any evidence base that would support that this is a thing that won't be that bad.
Yeah, no, I wasn't
Yeah, no, I
optimistic
mean,
that there would be one, but just curious if
yeah,
there's any actual response other than like no. Um,
yeah, I've got nothing, but maybe something exists somewhere that I'm not aware of.
Jean Keller, I see you've got your hand up.
Uh, Yes, thank you. So, oh, my camera's off as usual. So this is this is more of a comment than a question. I'm particularly concerned about the loss of Part D funds because those funds are for WICI, women, infant, children, and youth. And I think one of the most effective Ryan White programs has been the near elimination of vertical transmission of HIV to infants. And I am, and if that funding goes away, we will see an increase in the number of babies born. So I just wanted to, just point that out. The other thing is that, and I'm not sure if you know this, is that ADAP is often used to purchase insurance. So it's not just HIV care that's going to be lost. It's going to be sort of all the other things that go with it. So that's just my 2 cents worth. Thank you so much. This was really interesting. And of course, something I worry about all the time.
Yeah, and I mean, you're pointing out limitations, right? And we
Yeah.
didn't explicitly look at maternal fetal transmission. That would go.
Yeah.
We didn't look at other ADAP things, right? The only excuse I can plead is we were hustling to get things out as soon as we can, and
Yeah.
we picked what we thought we could answer quickly.
Yeah. Oh
But
no,
you're right,
that would be just really very focused, and I understand why you didn't look at it.
right? No,
It's
right, but
my
you're right. I mean, but there's a bunch of things like that, right, that we didn't pick on.
yeah.
So you could say that all these things are probably going to make things look even worse, right, than what you see here.
Excuse me, my phone just rang.
Yeah, I do wonder though. I mean, that does seem like, you know, the and the appealing to hearts and minds, as you think about your future research projects and like the idea of perinatal transmission and like which is like a no fault. There's no room to blame anyone there. Um, might be one of the ones that might be, again, not that you were intending to be a politician, but
Yeah, no, I think that's a great suggestion. One I'd not thought of specifically, right? And I mean, right, you could do a little more work and think about, mothers and new babies and the way that would affect things. Yeah.
Joyce.
Yeah, I just want to really thank Todd for putting together this research so quickly and so thoughtfully. I mean, it's very complicated. Obviously, the model that you created is really excellent, and then to sort of quickly get a handle on these different funding mechanisms. Just want to say thank you. So important during this time. And this is something that we can point to, right? There's something concrete that we can point to. I'm also just thinking that it might be powerful and maybe I know Jeannie is on the call here and Alison Agu is very involved in HIV-MA. I just wonder about pairing this kind of work with some testimonials from patients who have received Ryan White funding. And, this is making making these decisions that in the abstract are abstract, right? And like so many people think that HIV is not a problem anymore in the United States. You know, when we make it real for people, then it's real. And so I just wonder about being able to use this research alongside with, you know, real people testimonial. I think that that could be really powerful. So just want to say thank you. And I think, you know, the future directions seem spot on also.
Thanks, Joyce, and I appreciate all your help too in thinking through these things.
And Joyce, just to piggyback on that, I wonder also if it like a comment from case management, actually. You know, we don't always think about them as like as having such, but they have such direct interaction with patients. And when they have no resources to offer, like they are like in a desperate situation. Like I think that also might provide some of that comment, like where about how hard it is.
Right. Yeah, no, and I think, you know, one of the other thing I was thinking about is just, you know, how in Washington State there is an example of ADAP going away. And this is a thing, you know, that these requirements for proving that you're eligible, that's like a decent amount of bandwidth. And that's a lot both on patients who already may have difficulties doing those things, and then on staff. I can't tell you how much time the staff spends, you know, getting confirmation and proving that people are eligible for these resources, and that's likely only to get worse in terms of what's required to prove that you deserve, right, to have these resources.
Yeah, I mean, thank you. I think that's well taken.
And one other question that, again, I'm afraid is like asking you too much outside. I mean, it's sort of like as we have this ongoing discussion about how healthcare should be funded in the United States, in many ways, Ryan White is an example of really like total healthcare where you only have to qualify by just having a diagnosis. And I do also think that like the kind of work that you do, and you know, capturing also what Jean Keller was saying that this can be used to purchase insurance could really highlight just how having insurance can improve outcomes for a whole population in a broader way, which is just like an interesting like sort of test case of something that wasn't necessarily intended to do that, but
Yeah, I mean, it was on the agenda. I mean, at some point was to look at insurance questions in you know in states and what would improving access to care do, right? I mean, visually
mhm,
we'd envision this model to be like, what if you did like X good thing, what would happen?
right.
And then we pivoted to being like, what if you do X bad thing?
That sounds so nice. Yeah.
But yes, but at some point, I think we'd like to get back to those sorts of questions, like what if you did this good thing?
Yeah,
Um,
and just all the other like because you have this elegant marker, right? HIV viral suppression and new infections and but like there's also probably a whole bunch of data about all the other things that happen to people and the massive cost of all of those things happening and not getting addressed in a timely way.
mhm.
Um, are also like another argument towards the wisdom of caring for people.
Yeah, yeah, thank you. That's a good suggestion.
Anyone else with burning questions as we're right at the top of the hour? Well, thank you so much and for explaining this model in such easily like I could follow. It was very digestible, like and that is not easy to do. So we're very grateful for you taking all of this time and for you and your whole team for all the work that you're doing. It is so meaningful.
Well, thank you. I really appreciate the opportunity to talk to everyone. So thank you.
Yes, Joyce is glad you love math. So all right, everyone, have a wonderful weekend and a great Thanksgiving, and we'll see you the first week of December.